Hello everyone, good evening and Assalamu alaikum. How's everyone doing? This is Dr. Zaib Qureshi this end.
Evening, ma'am.
Hi Deepak, how are you?
Yes, ma'am, I'm fine.
Okay, that's great. Good to see you. Good to see you. So, hi Nazneen. Hi, how are
Hi,
you?
Assalamualaikum, ma'am.
Walaikum assalam. Walaikum assalam. Good to see you. Good to see you. Can you please write in the group that please join everyone? So, we will have a complete, the guidance how to crack exam smartly. Nazneen, can you please do that for me?
Yeah, okay, ma'am. I'm trying.
Okay, thank you. Hi, Hina. Hi, Aza, my girl. Walaikum assalam. I hope everyone is doing good. So today, I'm sure you guys are in full swings before September exam, and hardly, the 1 week is left, or 1 month is left exactly. So today is what? Today is 19 and tomorrow is 20th, and then exactly after that we are going to have the our exam. Hi, Hafiz. Thank you so walaikum assalam. So I hope you guys are preparing well and revising well as well. So in today's agenda, me and Dr. Maliha, I think Dr. Maliha is here. Hi, Dr. Maliha, how are you?
Hello, Dr. Zaib.
Hi. How are you, sweetheart?
Yeah, I'm doing fine. How are you?
Alhamdulillah, I'm good too. So we are just going to start in like in few more minutes, okay? Let other candidates join in, then we are going to start, okay? So
Okay,
before
sure.
that, if anyone
Okay,
has
sure.
any general question regarding preparation, regarding anything, you guys can ask us. Mm-hmm. Okay. Walaikum assalam, Muna. How are you? I'm good, alhamdulillah. Thank you so much. Good to see you. Okay. So I think let's get started. Yes, I know you are a strong soul, and I'm sure you will crack it. Okay. So all we need is courage. All we need is we just have to go on. We don't have to stop. Okay. See, like I always tell you, Mona, that quitting is not an option, right? If we are in this journey, so we have to be in this journey with our full zeal, full strength, and we have to prepare for this exam with full throttle. Okay, and because we are not sure that what exactly is going to happen on exam day, but this way or that way, we have to give our 100%. Okay, nobody can predict how hard exam is going to be, how bad in fact it is going to be or something. But see, candidates do pass and candidates do fail. We only have got the two exam results. Always we get the two results. Either one can pass, either one can fail. I can totally relate to your feelings, Mona, trust me. Okay, so so I know how you are feeling, but the problem is we can't stop. Okay, we can't stop. So yes, inshallah. And of course, after believing in yourself, you have to believe in God as well, that if God can put you through it, he can make you through it as well. So just to stay patient. Okay, just hang in there. You just have to study. Okay, inshallah, I am with you, Mona. Okay, you know that. Okay, and I will be with you till you become a MRCOG, and that's my promise. Okay, so you don't have to be worried about it. And inshallah, so let's get started, guys. So okay, so I welcome you all. I, Dr. Zaib Qureshi, first of all, and I'm sure the many of you guys know me. And if you don't know me, I'm a, the senior mentor at Med Exam Expert. I am FCPS from Pakistan, MRCOG from UK, MRCPI from Ireland, and a European board, the fellowship holder as well. Okay, so this is my brief interview. I'm currently working in Karachi, Pakistan, and I am working as the consultant obstetric and gynecologist. So anyone, who is in Pakistan and who is in Karachi, are welcome to, approach me or talk to me in person as well. Okay. And apart from that, I'm almost available because we work online, of course, so we are almost online. So I'm in here, Pakistan, Dr. Maliha is in Bangladesh. So any candidate who needs any kind of assistance in terms of, the preparation or anything, so you guys are more than welcome to, approach to us, talk to us, and, get an idea that, where you are lacking, what you need, and what you need to focus on, especially for this exam. Okay. So today exclusively we are here to talk about that, how to crack exam smartly. I'm sure everybody knows, and I'm sure, by now all of you guys are, the expert. But, being, the complete MRC holders, we can just give you, the good idea that how you can approach to, smartly to the questions, how you can, approach to your exams and everything. Okay. So we are going to the briefly talk about that how to crack exam smartly, and then, later in the session we are going to do very, the good question practice as well. Okay. So be there and don't go anywhere. You have to be with us for like, 1.5 hours. Okay. So you have to be with us. All right. So let me start with, and so let's just focus on this thing first of all. So we always say that patience, persistence, and perspiration make an unbeatable combination for success. Is it true or is it not true? It is true, right? So we always say that, you need to be patient, you have to be persistent. Okay. And, you have to show your, the courage as well, that, how you are going to succeed in any of the exam, isn't it? See, once you will stop studying, of course, you will forget everything. Once you will restart your studying, you have to start it from scratch. Okay. So all you need is patience. This exam is not like, easy. This is not an easy ride. Of course, you have to put your 100% efforts into it. You have to give your 100% and even, the more than that. Okay. So, for me, what matters the most in this is persistent in this journey. Persistence. Okay. Patience is everybody's virtue. Patience has a virtue as well. Okay. And everybody has a different level of patience as well. But for me, persistence is the key. Persistence is a key to success. Okay. But what causes us to be persistent? Sometimes there are two things which lead to it. Number one, passion and faith. Passion what? Passion means you have to be passionate that yes, I have to become a MRCOG, so I have to be passionate at all times. You have an ambition to become a MRCOG one day, or perhaps, to relocate to UK or Ireland for, the better perspective. So, if you have passion, so it will drive our will and ambition. It makes us crave success. It's an emotion that is so strong, and trust me, there is no alternative. Passion must be followed. Okay. If you are passionate to do anything, so you have to follow that. All right. So faith is also important, because without it, success is near impossible. If you don't believe in yourself, if you don't believe in this, that you can achieve it, how will you ever reach to it? Yeah, isn't it? So you have to believe in yourself. You have to remind yourself on daily basis that yes, I can do it, I can do it, I can do it. It's not like that, I cannot. I can. Always remember. Okay, make it a reminder for yourself on your mobile, on your laptop, on your desktop, wherever you study. Okay, all the time you have to repeat it to yourself that yes, I can do it, I can do it. Okay. So for me, ambition is the path to success. Persistence is the vehicle you drive in. Persistence rejects knockbacks and failures. It moves forward no matter what, isn't it? So a little patience, persistence, and perspiration make an unbeatable combination for success. Okay. So I think with this positive note, we can move on. All right. So this is just to encourage you guys that, don't be upset about any obstacle. Once you are through this journey, trust me, you will love your journey afterwards. Okay. Doesn't matter how hard it is, doesn't matter how impossible it looks. But of course, once, the result is good, once you will become a MRCOG, you will forget each and everything. every candidate go through, the more or less the similar times, okay? Because, the more or less we all are working, many of us are, having the family responsibilities as well, plus, we are studying, or, of course, it looks so hard. But, if we will give over 100%, and if we will be patient, but, persistence is the key, okay? So I hope you guys will remember now, and you will remind it to yourself all the time that yes, I can do it. Yes, I can do it. Doesn't matter how hard it is. Doesn't matter how difficult it is. Okay? Are you guys with me? Hmm? Yeah? Okay, very good. So let's talk about exam now. So we all know that we have got two papers. Okay, one is obstetrics and the other is gynecology. And there is no hard and fast rule that which paper is going to be the first one, okay, the obstetrics, or the second is going to be the gynecology, or is it solely going to be the obs paper, or is it solely going to be the gynecology paper. But moreover, okay, in both papers you can get, some of the questions, but the major weightage is going to be of the obstetrics obs paper, and in the gynecology paper major weightage is going to be of gynecology. Then, the paper pattern is going to be paper 1, paper 2. Roughly, we always say that, in paper 1, 50 questions are going to be there for the single best answers and 50 EMQs, and total duration is 3 hours. And almost we say that, the marks, 40% will be, the marks in the SPA, and 60% EMQs will have a weightage. Okay. And you have to solve 100% of them. You can't leave any question, unsolved. If you feel that, because since it is a Pearson View Center, the exam question it's in the computer based exam, so of course, on the, the window you will have something, it is going to tell you that, whether you have to come back to this question. We call it as a flagged question or unanswered one. Okay. So if, for example, you have, the started with question number 1, then you got stuck at question number 12, then, everything was fine till 20, then you got stuck at 22. Okay. So mark it as flagged. Okay. Unanswered. So for example, in one go, you have answered almost, 70 to 80 questions, doesn't matter. Then in 7 go, answer those which have been unanswered, because that needs your attention. Okay. That needs your a lot of attention. So roughly we say that at least you have to give 70 minutes to SPA, single best answers, okay? Or 50 is going to be enough as well, or 1.5 minutes to each SPA, okay? For EMQs, yes, because in each EMQs, there are going to be number of options, then there are going to be number of questions. Then before reading every question, you have to go through options A to Z. I mean, doesn't matter how many options are there. Okay, so total is going to be the 3 hours. In 190 minutes, in 3 hours you have to solve 100% of your paper. Okay, means the 100 questions, 50 single best answers, 50 extended match questions, and the first paper is going to be done. Then you will have a break time. In that, the break time, either if you are allowed to have, the coffee or tea or anything edible, so you can have that. Okay. So after 3 hours, you will have almost 1 hour break. And then after that, you will have a paper 2. In again, paper 2, the same questions will repeat. Okay. Again, 3 hours paper, you have to solve all 100 questions, and altogether it's going to be 180 minutes. And this is a rough strategy. Okay. This is a rough strategy for which almost every, the expert mentor agrees, that you have to give more time to extended match questions rather than single best answers, because single best answers are sometimes, very easy to answer. How? Because the answer sometimes is going to be very obvious. Okay. For example, it is going to be straight, the percentage question. For example, it is going to be straight any computation question. For example, it is going to be any obvious, the question which already, many times. Okay. And then second question arises, which candidates, love to talk about, is that, how much is the, the paper is being repeated from the past papers. And this is very hard to say in the current, the scenarios in 2022 and in 2021, the scenario has been changed a lot. Okay. Now there is very less repetition. Okay. As such of the questions. Of course, curriculum is not going to be changed. For example, shoulder dystocia is an important guideline. Labor delivery is an important module. PPH is an important, the chapter. So of course you will get, the questions from this. So once you will get question from that, don't think that this is from the repeat question. No, this is from the important curriculum, which can never be neglected. If you are missing shoulder dystocia, if you are missing quad prolapse, labor delivery, PPH, APH, vasophobia, okay, placenta previa or something, of course, your obstetrics is not going to be completed. Okay, so please, always think of that. There are, the number of potential guidelines which have, the likely chances to be repeated. So please have, the focus on them. Guidelines, nice guidelines, green top guidelines, of course, and some of the important talk articles as well. Then, exam questions weightage, like I have already told you, that 40% is going to be single best answers and 60% are going to be the EMQs. And of course, EMQs will give you, a very hard time because you have to think, okay, for example, in EMQs, you will get, from the options A. In my exam, I had from A to S options and I had almost 4 questions. And after reading one question, I have to scan all options again and again. That's why it is said that you have to give extra time to EMQs. You have to scan all the likely options, okay, and narrow down then, okay, narrow down your options. For example, if the question is about shoulder dystocia and they're asking about what could be the risk factor, so try to find out what could be the most potential risk factor, okay, because there can be the number of risk factors. Okay, then you have to narrow down. Okay, it cannot be. Okay, it cannot be. Okay, it can be. It could be. It possibly can be or cannot be, and it is not an option. It is not an option. So you will narrow down. By the end, you are left with 1 or 2 options. Then you have to choose out of that. And the same strategy you have to apply in the single best answers, because in single best answers, out of 5 the stems, or out of 5 options, you might the exclude 3 options straight away. You can say no, this cannot be the option. Then you might be thinking in between the 2 options, okay, because it is the single best. You don't have to choose the right option. You have to choose the best answer which fits the best to the scenario. Okay, so in EMQs, always remember that you have to give the extra emphasis. You have to the practice a lot. You have to give your time to the EMQs, because EMQ needs a lot of the mind rehearsal, and it needs a lot of practice as well. Then comes the revision time. How do you revise? It is very much important. How much do you retain? It is very much important. How far you have studied at a module, how many sources you have been following, that is going to count in the revision. Okay, that's why we always recommend that you have to study from the recommended sources. Okay, number 1. Number 2, strategy. If there are multiple sources, if there are multiple the things to revise from for single topic, don't follow all sources. We are not in undergraduate the exams in which we are so much keen to learn, we are so eager to learn, and even in that undergraduate level, we are not having the responsibilities what we are having at this moment, okay, at the postgraduate level. All right, so your mind is a kind of the place which will store information, which will reproduce information. Some of the information is going to be very fresh, some of the information will go to the subconscious, some of the information will be revoked on certain the responses. I'm sure this is a normal phenomena, right? So you don't have to put extra burden on your neurons as well. Okay, so all the time you have to have your neurons the active as well. Okay, yes, you have to pass both. Okay, so SBA and EMQs to pass the exam, because the result is going to be the collective from paper 1 and paper 2. Okay, and nobody can say that how much you have to score in paper 1 or paper 2. Earlier, back in 2016-17, it has to be the separate. Okay, but since 2018 onwards, it is now collective result. Okay, so you have to pass from both of the the papers. All right, so I was on that don't put extra burden on your brain. Okay, give your brain some time to rehearse, to reproduce the knowledge what you have studied so far. Okay, and it has to be fresh, it has to be the kind of the in a good state, that at least once it is reproduced, so you can, recall that, okay, I have studied this, okay, I have studied this, okay, I know about this, okay. So, the mind has a tendency, subconscious has a tendency that, not every information will be, will be fresh. Of course, sometimes, the very remote knowledge works as well, okay. So, don't put extra burden on yourself as well, that you are studying one topic from so many sources, okay. So you don't need to do that at all. Then curriculum. So we all know about curriculum, that green top guideline, that makes 60% of the curriculum. Then comes nice guideline, because almost medical disorders are to be covered from nice guidelines, isn't it? Diabetes, hypertension, okay, labor guidelines, then cesarean section guideline. So almost all important guidelines are from nice guidelines. So you have to cover nice guidelines very properly, because this is going to be the major chunk of ops paper. Then talks will carry 20 to 30% of the weightage, okay, in terms of that you have to study almost, the last 3 years or 3 to 5 years. I always suggest at least 3 to 5 years talks. And in every year, you will have 4 issues, okay. 4 issues mean 4 times it is being released, okay. And in one talk article, you will have 5 articles. Then out of those 5 articles, always, look at which one is the important, which one is irrelevant, which one needs to be done on the priority basis, okay. So make a list for yourself, okay, prioritize. I'm sure by now all of you guys are studying, making your own notes, it's a very good habit, and it's a good idea that you have to make, your own notes, your own, the small the flashcards as well to revise from in the end. Then some of the FSRH guideline. FSRH is Faculty of Sexual and Reproductive Health, okay. So, okay, here there are plenty of guidelines, almost 50 plus guidelines. You don't have to study 50 plus guidelines, yeah, because FSRH itself is a, the complete diploma at UK, okay. This is Sexual and Reproductive Health Diploma. So those guidelines are for them. But for you at this level, the important guidelines to be studied, for example, contraceptive guidelines, combined hormonal contraceptives, progesterone only contraceptives, intrauterine contraceptives, emergency contraceptives, contraception after cardiac disease. Because, according to the recent 3 recent MB race reports, the cause of death is going to be the cardiac diseases. Yeah. So they are, these days they are emphasizing on cardiac diseases. Okay, they are bringing so many questions from cardiac diseases. So you have to study cardiac disease from every aspect there is. Some of the BASH guidelines is, British Association of Sexual Health, the guidelines. So you have to do them as well. Not all are important, but, some of them are very much important, of course, chlamydia, gonorrhea, okay, trichomonas, syphilis, candida. So, you have to do them, on the priority basis. Consent advices, yeah, so many numbers. Don't forget to revise them, okay. MB race reports, recent 2 MB race reports should be done as well. Some scientific impact papers are important, like, the vitamin D, like analgesia, like some of the, you can, quickly scan, and then you can simply, just go through about the scientific impact papers as well. But yet again, don't forget that your main and foremost priority is green top guideline, okay. So don't forget this thing, okay. Don't focus on, the minor stuff, okay. Don't the focus on, all these things. Rather, your focus should be, these 3 main areas first, and then of course, the rest of the 5 to 10% of the paper is going to be from here. Okay, clear so far, everyone? Clear, everyone?
Assalamu alaikum, ma'am. Sorry, I missed
Walaikum
what you said
salam.
about the consent advice. We have to do the all consent advice.
All
papers
consent
or-
advices, okay, all numbers.
Okay, thank you.
Okay, that's good. Okay, that's great. Okay, let's move on. Then, the knowledge-based modules to focus on for the exam purpose. Okay, so what you have to do, core surgical modules, roughly 10 questions can come from here. Okay, biostatistics, roughly 6 to 8 questions can come. Teaching and clinical governance module, 10 questions can come. Maternal medicine module, it's a major chunk of ops paper, okay, along with labor and delivery, because labor and delivery is going to be along with this maternal medicine as well and everything, okay. Then it is going to be there. Then oncology, urogynecology, benign gynecology is going to be the major chunk of gynae paper, okay. So you don't have to forget all these the kind of important stuff. So what I advise to my all students all the time is that maternal medicine should be on your tapes, labor delivery scenarios should be on your tapes, urogynecology, some of the oncology from the NHS cervical screening program, that is very much important, it should be on your tips, okay. From benign gynecology, HMB, PMS, CPP, it is very much important, because PMS is not going to leave you even you become MRCOG, and you will have a scenario in part 3 as well. CPP, you will have a scenario in part 3, polycystic ovary. So, I mean, your concepts should be very clear at this level. You should have a very clear knowledge that how you are going to manage with the PMS, because PMS, one EMQ is must. CPP, SBA or EMQ is must. Polycystic ovary, yeah, it is going to come. HMB, yeah, very much important. Then hyperplasia guideline, yeah, endometrial hyperplasia, it is definitely going to come. Always remember, for the guidelines who have algorithms, always remember, for the TOG articles who have algorithms in the the end of the guideline or the TOG article, these are almost must to come questions in exam, mark my words, okay. So what you have to do is, you have to make a separate folder, okay. You can print them, okay, you can print all algorithms, okay, and it's a good idea to revise them on daily basis as well. All right. Till date, I think it's been like 4 years I'm MRCOG now. Yes. So, but still I have, my own notes with me, my own diaries with me, my own, the algorithms with me, and day to day I do try to add them. When I see there is new guideline, new talk article, okay, I do try to add, because that is a kind of, the whole, what I can say, a kind of, the major stuff for me to revise from. Okay. So this is what a good candidate has to do all the time, okay. Prioritize your stuff, don't rely on ready-made stuff, okay, because everybody has a different thought process. You can study, but it's better to study yourself first and then take help from the ready-made sources, okay. Then this is a major area which I want to talk about: strategies, general strategies to solve questions. First of all, because you still have got time, you have to revise your own notes time to time if you have made any, okay. You have to revise all algorithms on daily basis in one dedicated hour when you are fresh, okay. For example, we do have endometrial hyperplasia, we do have PMS, okay. We do have what else, which algorithm we do have, GBS, we do have placenta previa, we do have placenta accreta spectrum, okay. So almost all these algorithms, SGA guideline, VTE guideline algorithms, okay. So these algorithms should be on your tips, because VTE risk factors, SGA risk factors, they are very much important, and we tend to forget them, yeah. So in real exam, you're not going to have guidelines with you. All you have to use is your neurons, isn't it? So revise all those algorithms on daily basis. The best strategy is that if you are not the kind of computer person all the time, so it's a good idea that you can print them, okay. I still have my printer with me, so I do print my stuff on myself, okay. I do keep it with me, so I can add the many points on the back of that, the paper, one paper, algorithm paper. So by the end of my study, I have my own notes ready to revise from. So isn't it a good idea? Yeah. So you can also try that. So you can start from the book to book or module to module as well. There are different strategies that how you are going to solve questions. Some people prefer the module to module, some people prefer the book to book, okay. And for me, by the end of preparation, it doesn't make any difference anymore, okay. This way or that way you have to study, this way or that way you have to the revise the important modules. You have to do the, don't just memorize questions, okay. Don't just memorize question. This is another tip, because questions can change, but your concept should be very clear. Concepts are not going to go anywhere. So your concept should be very clear. Okay, you have to have a clear idea about the all topics, everything. You have to give equal attention to theory and the questions as well. Don't do all the time questions. Okay, so you can roughly divide your time into when you have to do the revision, okay, and when you have to do the question practice. For me, like I'm a morning person, so in the morning time the neurons are quite fresh, so I used to revise my the stuff in the morning, and then after coming from work or even at work I used to do the questions. Okay, so after coming from work, because you cannot focus that much, so I mean you can give the dedicated 1 to 2 to 3 or 4 hours, and close to exam it's a good idea that take off from your work, okay, 10 to 15 days maximum, maximum, minimum, sorry. So maximum it could be whatever you can afford, okay, from your the schedule and all. So but revise on daily basis. For example, I used to make the my own schedule. I used to make that, for example, I have to cover the all ops guidelines first, or all gynae guidelines first, or according to the the modules, or according to the books. So I used to study with my one of the study partners, so we had a very good bonding, so we both used to study over phone. So she was from India, I was from Pakistan, so we used to study. I still miss her, and so this happens, okay. So if you are studying with a group, so it's a good idea. Group study is always good, because sometimes if you get stuck, if sometimes if you can't answer, so somebody can help you, okay. Even if not, so you can study on yourself. Whole life we doctors are going through these exams, isn't it? So by the time we are in this journey, we are almost I mean, good to go for every exam there is. Okay. But again, I will do this. I will tell you guys the same, that do revise and do question practice on daily basis. Have more focus on EMQs. Like Dr. Maliha said just now, that 60% of the EMQs needs to be passed for exam, because it has a greater weightage, isn't it? But nobody can tell you that, in paper one or paper two, it is the separate marks. Okay. But of course, overall, RCOG has a different criteria to give, the marks accordingly. So, you have to, you just have to, do the practice. Then while you are practicing, for example, you have to mark your weak area, and then you have to give extra revision to that module. For example, for me, some of the modules have been so difficult while I was a student like you. Okay. So in the end, I gave, the dedicated, the 2 to 3 days to that module, just to only to that module. So of course you have to give, the equal attention to all modules. You have to give, the complete question practice to all these things. Okay. So these are the general strategies that how you can solve question. Is it clear, everyone? Any question? Or would you like me to add any other thing? Hina, Afreen, Ala, Aza, Marwa, Sarah, is everything clear? Okay, it's okay. Very good, very good, very good. All good, all good. Okay. So we are good to go. So, recommended books to practice from, these are the recommended books. Okay. But again, because some of the books are old edition and many guidelines have been revised lately, so you have to, I mean, put your guideline reference. But these are almost, the quality books question. Okay. Questions are like, quality questions. So for me, in preference, what I will suggest all of you is, for EMQs, you can pick Justin Kuhne book, Andrew Sizer book, P. Sinha book, Tahir Mahmood. This is my all-time favorite book. It has very, the quality questions. But of course, you have to be careful with the keys. Okay. This Rekha Bhutangal, I love this book. EMQs are very much important. Okay. Not SAQ1, the new edition. Okay. SBA. So it is important. Get through is good. Okay. For single best answers, you can do Justin Kuhne book. You can do Amanda Jones. You can do Brian Magwan. Okay. For succeeding, because it has some printing error, some of the keys are, in a reverse order, and in a, the kind of that order. So for me, this has to be in the end. Okay, the succeeding Oshmishtha. Okay, it has to be in the end because it needs a lot of your focus, that what you have to cover from. Then comes, in terms of online sources, what you have to study. From online sources, strategy e-learning is always recommended. Then you can take Pass MRCOG subscription as well. Okay, you have to take at least 2 to 3 thorough revision to practice from strategy till exam. You have to put more focus on explanations rather than questions. Okay, because some of the questions from explanations you can get many questions as well. Okay, so take if anybody who is interested even now for till 1 month, you can take e-learning subscription. Be an MRCOG associate. Okay, log into your MRCOG account and just search MRCOG associate. It will give you a link. Become an MRCOG associate and pay according to your country's band. Okay. So of course there is going to be fee, and that fee is going to be for 1 year. All right. So it's a good idea that you have to do all these questions from strategy e-learning. By the end, guys, you have to be positive towards what you learn and try to absorb it with examples, references, and reasoning. Okay, so you have to prepare yourself for I always say that concepts. Okay, if your concepts are clear, if you know this answer is from that book, that talk article, that guideline, then of course you are good to go. You know from where the references, you know where is it written. Okay, you know that why the answer is this. Remember, when there is no how, why, when, and what, then none of the education is complete. I'm sure you all know this. Okay, so by the end, you have to be positive. You have to be positive all the time. So this is an idea. So me and Dr. Maliha, we both are bringing the very important exam like questions workshop. Okay, so you are going to have the 5 days discussion with both of us on Telegram. So it's going to be held in the first week of September more likely, and moreover, you will have very good time with us. And we had done this workshop in the July exam as well, and we had a very the good response, and candidates were the like very active, and candidates were like discussing on daily basis. And of course we will be with you till your exams. Okay, so all you have to do is just the work hard, work smart, stay focused, just focus on your the questions, focus on your goal, that you have to be what you have to be MRCOG, isn't it? So if your the goal is clear, if then of course your agenda is going to be clear as well. Okay, so if anybody is interested in taking this workshop, you can contact us. You can contact the med exam, me and Dr. Maliha in person as well. So I think the fee is quite reasonable as well. So even if somebody has any kind of the problem, so we can adjust accordingly. Okay, so okay, Sarah, my team member will contact you, sweetheart. Okay. Yeah, sure, Afrin, sure. So we will provide a link to all of you. If anybody is interested for rapid revision, rapid, the learning, we are there to, the help. Even without, these workshops, I do try to answer on daily basis for multiple queries with the best of my capacity and capability. Okay. So, me and Dr. Maliha will be there, of course, for dedicated 5 days with you. So I think you can get, the extra, the care and extra, the important type of the questions will be discussed as well. So of course we will be with you. Why? The reason why we have kept it close to the exam date, because you need fresh revision. Because once your the revision is fresh, your mind will have a good capacity to reproduce it in the exam hall, even if you haven't studied that thing for quite long. But if you have done this discussion, so you can remember, okay, I have discussed it that time, okay, I have discussed it with that person that time. All right. So yeah, if anybody is the willing, so you guys can join us. We will be so happy to be of help, and we will be so happy to guide you through as well. All right. So you guys can contact with the med exam expert team, me, Dr. Maliha, anyone. We are on Facebook, we are on Telegram, we are on WhatsApp, we are everywhere. Okay. Okay. So let's practice some of the questions. Now I will, hand over the session to Dr. Maliha. Dr. Maliha, if you would like to add something.
Okay. So, yeah, I'd like to say something to the candidates because it's for those who are giving their exam on September. Uh, just one thing that definitely we do not know everything because, and it's also not possible since the syllabus is very vast.
Hmm.
And as Dr. Zaib has already said that every 3 monthly new talks are coming and also there are revised versions of GTGs. So one plan you need to make that is you need to study together. You need to make
Hmm.
your own group, like group of 2, 3, 4, 5, or even more.
Hmm.
And
Hmm.
because that's how you get to know that what materials you are studying is adequate for the exam or not.
Hmm.
Because you will get to know about this, about making your group.
Hmm.
And I would also like to say that do not go by others, choose your own way.
Hmm.
Others may require 3 to 4 months to prepare for the whole exam. You may need a little longer time or even lesser than that.
Hmm.
But and try to stick on your own study routine. Like if you get only 2 to 3 hours to study, it's okay. But try to stick on your own schedule. Do not miss a
Hmm.
single day for study. Because you might get depressed seeing others that she is getting 10 hours or 12 hours or even whole day for study because she is not doing anything, but I am doing, but or I have to do my hospital work or my regular
Hmm.
work or even my family. I have to look after my family. But one advice from my side is try to stick on your own schedule and also prepare your own notes. Whatever you are getting from different sources your friends are giving or you are getting from any coaching or any some materials are even free in different in various groups. So try to make your own folder of each module.
Hmm.
Because as I have seen that we love to study the GTG and NICE because NICE guideline because they are written in a beautifully way. But
Hmm.
yeah, there are talks article and strategy. These are a bit vast. So make your own notes and
Hmm.
because it will help you before your exam for revision.
Hmm.
And the last thing is solving questions. As Dr. Zaid has already said that try to study the whole bulk, whole contents in the earlier part of the day because our neurons used to get fresh at that time. And try to solve relevant question. Before solving question, either you are solving the recalls or solving the books question, but try to study the relevant guideline at first. Don't try to jump solving questions
Hmm.
all of a sudden. First, read the guideline, or we have talk articles in some on some chapters. Those who we don't have the GTGs or NICE, but we have to read those chapters from the talks article. So read that talk article and solve all the at the last of the talk article we do have some questions, try to solve those also. And also solve the last 3 year talks article. They are really
Hmm.
important before exam.
Exactly.
So it's better to go by plan rather than not having plan at all. So
Yes. Very
that's what I
wonderful
want to say.
advice.
Yeah.
Yes, yes, yes. Thank you. Thank you so
Yeah.
much. Now over to you, Maliha. So guys, we are going to
Yeah.
solve questions now. Okay. So just be there.
Are you able to see my screen?
No.
Okay.
Screen is not visible.
Mm. Now?
Not yet.
No.
Not yet.
Go to the Zoom, okay? And then there is going to be an option, okay? Share screen. Then you can share screen.
Yeah, share screen is coming.
Mm-hmm. Then you have to click on your screen, which screen you want to show.
Yeah, I have already opened my PPT, but I
Okay, let me
don't know what's
tell
the
you.
problem is.
No problem. Hold on. Let me tell you.
Yeah. Mhm. Uh, now it's okay? Hello?
Yes,
Yes.
yes, we can hear you. We can hear you.
Okay. You can see my slide or not?
Yes, yes.
Okay. So let's start. I'm really sorry, guys, for having this unnecessary delay. Actually, I am newbie because I recently passed my MRCOG in February 2022. I have been a student of med exam during my part 2 and also my part 3 because I just remembered that I was giving my mock test with Dr. Zaib just in this February. So please bear with me. So
No,
shall
no,
we
it's
start?
okay. It's okay. It's okay. Yes, yes, please go ahead. Go ahead.
Okay.
It's okay,
Okay.
okay.
It's okay. It's okay.
Okay.
Yes, we
Thank
are
you,
with you.
everyone. Yeah. So today we are going to solve some EMQ from different modules because this is the questions actually where we used to fail. Actually, it is also for me also because we can't pick the buzzword. We can't pick what to get from the question. Okay, so that's why actually we can perform well in EMQ exam. So here is some of your options. Go through the options first, and then I'll show the question. You need to. Shall I change the slide? Have you gone through the options? You need to speak for me. Sorry, but I can't see the chat right now.
Yes, you can.
Okay, thank you. So here are your questions. So number 1, a 16-year-old girl presents with primary amenorrhea. She has normal secondary sexual development. Clinical examination reveals a short blind ending vagina. Her karyotype is 46XX. So let's get back to the options. So here are the options. What do you think? Which could be the answer? You need to speak,
MRKH.
sorry.
MRCOG.
It is F.
Yeah.
E. It is the E. Option
Yeah. Very good, MRKH, because in MRKH, just remember that the girl does not have her uterus, but she is having her ovaries. That's why she is getting her all the hormones and she's getting her sexual developments also. But as she does not have her uterus, so the primary amenorrhea is there. Number 2, a 15-year-old girl presents with amenorrhea and abdominal pain. Clinical examination reveals a pelvic mass and vaginal inspection demonstrates a pink bulging membrane. So the buzzword here is a pink bulging membrane.
I think improper hymen.
Now tell.
Transverse vaginal septum.
Okay.
C.
Yeah, very good.
Yes.
Okay. So let's get back to the question again. Here the buzzword is pink bulging membrane.
Imperforate
So
hymen.
in both cases, that is the transverse vaginal septum and imperforated hymen, we have the similar feature, like the girl is having amenorrhea, cyclical abdominal pain, which is increasing in each cycle. And if we do the pelvic examination of the girl, we can see a pelvic mass. And if we do the ultrasound, we can see the hematoculpus. Okay, so both are similar in so these features are similar in both cases, like in imperforated hymen and transverse vaginal septum. But when you do the vaginal examination with a speculum, pars speculum examination, we can see the bluish thin membrane in imperforated hymen. In imperforated hymen, you will get to see a thin membrane that is bluish, but pink bulging membrane, it can be seen in transverse vaginal septum. Clear? Clear, everyone?
Yeah, clear.
Okay. Now the third question. A 16-year-old girl presents with amenorrhea and delayed puberty. Phenotypically, she is female and the uterus is present. Her serum FSH level is elevated and her karyotype is 46XY. Remember the buzzword. Karyotype is 46XY. She is having delayed puberty and phenotypically she is female. Okay. What would be the answer? Do I need to go back to the question?
Sware syndrome.
Okay, why this is not androgen insensitivity syndrome?
Step slide back. Uterus is present in.
Yeah. Yeah, you are right.
Uterus is absent in
those
androgen
who-
insensitivity syndrome.
Yes, very good. Sware syndrome differs from AIS that uterus is present. In Sware syndrome, the girl will be or the person will have her uterus, but in androgen insensitivity syndrome, there is no uterus. But karyotype is same in both AIS and Sware syndrome, both having karyotype 46XY. So the buzzword here is, though the karyotype is 46XY, which is similar in both, but the buzzword is uterus is present. Do you get me?
Yeah.
Yes, ma'am.
Okay, thank you. So the questions for 4 to 6 options are these. First, you go through the option. Okay, so let's go to question number 4. A 38-year-old woman with heavy menstrual bleeding is seen in the gynecology clinic. Her medical history is unremarkable other than mild renal impairment. The woman is keen to avoid hormonal treatments. Okay, now let's get back to the options. Now, please tell me the answer.
Tranexamic acid.
Okay. Any
Tranexamic
other
acid.
one? Yes,
Tranexamic.
right. Yes, very good. Tranexamic acid, because she is having mild renal impairment, so we can't give NSAIDs or mefenamic acid or whatsoever. And she is also keen to avoid hormonal treatment. So she just come with the heavy menstrual bleeding. So the first line treatment would be tranexamic acid. Good. So number 5, a 35-year-old woman attends the gynecology clinic with heavy menstrual bleeding and dysmenorrhea. Her history is otherwise unremarkable, but a pelvic examination demonstrates an enlarged uterus with possible fibroids. A pelvic ultrasound scan is arranged, but the woman is desperate to start her treatment immediately. So the buzzword here is she is having menorrhagia and dysmenorrhea. She also have fibroids and she is desperate to start her treatment.
Mefenamic acid.
I think danazol.
Okay, why not tranexamic acid?
She's having
Danazol, okay.
dysmenorrhea.
Mefenamic acid, danazol, and why danazol?
Because they are
Is it
fibroid.
written in our guideline? Okay, so in our NICE guideline, is it written danazol?
No,
Is
I have
danazol
not
given
seen.
as option of treatment? Okay,
I have not
yeah,
read.
it's okay. No worries. It is mefenamic acid, because see, she is having both features, that is menorrhagia along with dysmenorrhea. Both features. and she is desperate to start her treatment. She is desperate. So we need to give her some treatment right away to stop her symptoms. So we can give NSAIDs. After that, we can evaluate her further and we can give hormonal treatment or surgical treatment, whatever she wants. Okay. So she is desperate to start treatment. This is the buzzword. So you can give either tranexamic acid or mefenamic acid. But why mefenamic acid? Because she is having dysmenorrhea also. Tranexamic acid will work for menorrhagia. But NSAIDs, if you give NSAIDs, mefenamic acid, it will work for both menorrhagia and dysmenorrhea. Okay. So question number 6. A 37-year-old woman with a BMI of 30.
Sorry, ma'am. I'm sorry,
Yes.
ma'am. We couldn't use here
Yeah.
Mirena because of dysmenorrhea.
Of course, we can use Mirena because Mirena is the first line treatment of heavy menstrual bleeding. But can you see the buzzword? Woman is desperate to start treatment immediately. Even if you want to give her Mirena or she wants Mirena, you need to evaluate her further because you need to wait for her cycle before giving Mirena. You need to do the pregnancy test before putting Mirena. You need
I got
to
it.
exclude if she has any pelvic inflammatory disease, but you need to give her some treatment right away because she is desperate. That's why it is mefenamic acid. Okay.
Thank you. Thank
Okay, thank you.
Okay. Yeah. So number 6, a 37-year-old woman with a BMI of 38 kg meter per square returns to the clinic for a review. She is para 2 and her family is complete. Her husband has had a vasectomy. 6 months earlier, she had an LNG IUS inserted for heavy menstrual bleeding. But this has recently been removed by the GP due to persistent vaginal bleeding. Prior to this, she had already tried tranexamic acid and mefenamic acid without effect. A previous pelvic examination suggested an enlarged uterus equivalent to 9 weeks of gestation, and a subsequent ultrasound scan demonstrated multiple small intramural fibroids. So the buzzword here is she has a very large BMI. She has completed her family. She already tried LNG, IUS, mefenamic acid, tranexamic acid without any effect. Now, what kind of treatment you can offer her?
Abdominal hysterectomy.
Hysterectomy.
Okay. Then why you want to do abdominal hysterectomy in a 37-year-old woman? Just because of she completed her family?
No option of TLAs.
Okay. Okay. Here, actually, the answer is endometrial ablation. L, second generation endometrial ablation. Why? Now I tell you. Because they have given you the indication of endometrial ablation. If you have read the endometrial ablation TOG article, we do have TOG article on endometrial ablation. These indications are written under the endometrial ablation where you can do the ablation. Wherever there is heavy menstrual bleeding due to fibroid, and you have to do can give her LNG IUS as a first line of treatment. You can do endometrial ablation, you can do uterine artery embolization, and for surgical treatment, you can go for myomectomy or hysterectomy. Now, here is the buzzword is they have given you the enlarged uterus, and the uterus is almost 9 weeks of gestation. So in the indication of endometrial ablation, it is written in that TOG article that you cannot do the ablation if the uterus is more than 10 weeks size. So 9 weeks falls under the indication. And also if the fibroid size is more than 4 centimeter, you cannot go for ablation. So it's less than 2 centimeter. These two are the indication of ablation. Why you will go for ablation in this question. Okay.
And what about the
Am I clear?
hysteroscopic section?
Hysteroscopic resection of what? Myomectomy, you are telling G,
Yeah,
option G?
yeah.
Okay. if we even do the myomectomy, this is intramural fibroid. Read the intramural fibroid. So hysteroscopic resection would be difficult. If it is submucous, okay, submucous fibroid, then we can go for hysteroscopic resection, but it is in the muscle layer.
Okay.
So, ma'am, here they
Clear?
wrote transcervical resection, endometrial ablation, and endometrial ablation. What is the difference?
Sorry, option L and option between
I mean,
P.
there is, yeah.
Okay, transcervical dissection of endometrium. Why? Why you want to do the dissection of endometrium for intramural fibroid? It's in the muscle layer. What will you do by dissecting the endometrium? But if we go for ablation, ablation is just to you will put some roller ball under hysteroscopic guidance and you will burn the layer. Okay, by that you will reduce the fibroid size, the volume size, and by this way she can get rid of her these symptoms.
Okay, thank you.
Clear?
Yes.
Okay. Moving on to next options. Okay. Next options are these. So what I'm exactly want to tell you that pick the buzzword in EMQ. EMQ is difficult, we all know. And yes, it's really hard to get the exact marking for EMQ. But you need to choose the buzzword. You need to pick the buzzword, what they intend to say. Okay. Number 7. A 13-year-old girl is brought to the gynecology OPD by her mother. Her mother is concerned that she has not had her periods regularly. She attained menarche at 12 years and had been having period once in a 3 or sometimes 2 or sometimes 3 months. She has a normal BMI and plays sport regularly. So the buzzword is this girl is only 13 years. She attained her menarche at 12 years and now she is having her period once in a 2 or 3 months. Okay. Now go for the option.
Reassurance.
Reassurance, huh?
Reassurance.
Yes,
Reassurance.
very good. Yes, very good, because we all know that irregular cycles are common initially few months after the menarche. So if this girl, if in this scenario they have given you that she is having normal BMI, plays sport regularly, but she is having heavy painful periods. If this is written in this question, so we need to further evaluate this girl. Okay. For this question, the answer is reassured, because we all know that is irregular period is common. But if this girl is having dysmenorrhea, menorrhagia, even after 2 or even if she is getting her period once in a 2 or 3 months with dysmenorrhea and menorrhagia, the answer would not be reassurance. The answer would be further evaluation of this girl. Okay. Number 8. A 23-year-old university student presents to the gynecology OPD with prolonged bleeding lasting for 9 days during her period. Although not particularly heavy, on questioning, she admits to have intermenstrual and postcoital bleeding intermittently. She uses the OC pill for contraception.
I think chlamydia.
Chlamydia screening.
Why you want to do chlamydia screening? Okay,
The
let's see the
PID.
question.
Suspected case of
Mhm.
PID. Was not using condoms, barrier methods.
Mhm.
Intermenstrual and
Yes,
postcoital.
very good. Yes, this is the answer. Chlamydia is always associated with intermenstrual bleeding. Intermenstrual bleeding in a young girl, less than 25 years. If you read the cervical screening guideline or badge guideline on chlamydia, there you will get to see that girl under the age of 25 years having intermenstrual bleeding, most common cause is chlamydia. Okay. So number 9, a 40-year-old woman who has recently come from Turkey presents with intermenstrual bleeding. She has not had any investigation so far. So you see, this woman is having intermenstrual bleeding, but 40 years.
Transvaginal ultrasonogram.
Okay. Everyone sure about this option, transvaginal ultrasound?
Yeah.
I think pap
Okay,
smear.
now go to the question again. Very good. Pap smear, because she is 40 years. Any abnormal bleeding at this age, remember, from 40 years to before the menopause, that is perimenopausal woman. From 40 years to 49 or 50, we all know that age of menopause is in UK is 51 years. So 40 to 50 years, if a woman comes with intermenstrual bleeding, you will first do the pap smear, because she has come from Turkey. It could be from any other country, but just remember that routine cervical screening is not available in many countries. And she might not have her cervical evaluation for so long. We don't know. Okay. So you will do the pap smear first. Remember, you will need to do the cervical evaluation first if a woman comes at this age with intermenstrual bleeding. Okay. Clear?
Clear, ma'am.
Okay. Number 10, a 54-year-old woman presents with spotting of blood vaginally on wiping over the last few weeks on and off. She went through the menopause 3 years ago and is otherwise well. She is more active since her knee replacement surgery. Her pap smear 2 years ago was normal, as were her other smears.
Transvaginal.
Transvaginal ultrasound.
Transvaginal.
Very good. In this case, we will go for transvaginal ultrasound because the pap smear is normal. Okay, and this woman is having postmenopausal bleeding. So the first investigation would be TBS. Now options for these questions. This is all about nerve injury. We do have a very good talk article on nerve injury. Let's go to the question. Okay, a 40-year-old woman underwent a total abdominal hysterectomy and bilateral salpingo-oophorectomy for severe endometriosis. On day 3 following the operation, she complains of weakness of hip flexion. On examination, the knee jerk reflex is absent and paresthesia is present over the anterior and medial thigh. So
Femoral
paresthesia is
Femoral nerve.
present in
Femoral
anterior
nerve.
and medial. Very good.
Femoral.
Yes,
Femoral.
we know that. Yeah, because in pelvic surgery, femoral neuropathy is common because of compression of the nerve against the pelvic side wall. Okay. A 60-year-old woman with a BMI of 40 had a total abdominal hysterectomy with bilateral salpingo-oophorectomy through a penisteal incision for a pelvic mass. She is now complaining of sharp burning pain from the incision site to the labia and thigh.
Iliohypogastric.
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 No, just
Yes,
she's
very
on.
good. Iliohypogastric. Yes, please speak.
Can you show the question, please, again?
Okay. Yes, everyone is right. Everyone is correct. It is iliohypogastric. We do know that both nerve, iliohypogastric and ilioinguinal, they do share the same nerve root, that is thoracic 12 and lumbar 1, right? But just remember that in penisteal incision, iliohypogastric nerve is more prone to injure. Okay, if you give the penisteal incision, iliohypogastric nerve is more prone. And also remember MLT, mons, labia, and thigh. MLT. It's written in the talk article that MLT, mons, labia, and thigh, sharp burning pain from the incision side to the mons, labia, and thigh is more common in iliohypogastric nerve. And in ilioinguinal, it should be in groin and inguinal region. Am I clear? If it's written that sharp burning pain from the incision side to the inguinal region or groin, then answer would be ilioinguinal. But here the answer is iliohypogastric. Okay, number 13. A 38-year-old woman underwent extensive surgery for carcinoma cervix stage 1B with lymph node dissection. She is now complaining of paresthesia over the labia majora and femoral triangle.
This is genitofemoral.
Genitofemoral now.
Yes, good. Genitofemoral nerve, because we know that this nerve is susceptible to injure during the pelvic sidewall surgery and also during removal of the external iliac lymph node. It is specifically written in that TOG article that
Yeah.
during removal of external iliac lymph node. Now, these options. Try to pick the buzzword. I can see that everyone is doing good. So you all are going for exam in this September? Those who are
Yeah.
answering?
Yeah.
Yes.
Okay,
No, I
very
am
good.
for
Inshallah,
January.
you all will get to. Okay, very good. Okay. Number 14. A 27-year-old woman presents to her GP with vaginal discharge, dysuria, and vulval irritation. Examination of the vulva shows purulent, frothy, malodorous discharge and punctate hemorrhage on the cervix. Strawberry cervix, punctate hemorrhage on the cervix is the buzzword here.
Trichomoniasis.
Trichomoniasis.
Yes, very good. So if this girl is coming with this feature and if you do the pars speculum examination, you can see that multiple punctation hemorrhagic spot on the cervix, making the cervix like a strawberry appearance. Okay, this is common in trichomonas infection. Also, severe itching. Severe itching is another buzzword. Very intense itching, severe itching is shown in, we can see in trichomonas infection. Okay. Number 15, a 44-year-old woman presents to her GP with itching and burning of her vulva and difficulty in passing urine. On examination, the vulva is erythematous and swollen and a curdy white discharge is present. This is
Candidiasis.
very easy, I think.
Candidiasis.
Yeah, without any doubt. Yeah, no need of explanation. Okay, number 16, a 25-year-old woman presents to her GP with vulval irritation and finding difficulty in passing urine. On examination, there are vesicles around the introitus. Vesicles around the introitus and
Herpes.
inability
Genital
to
herpes.
pass urine.
Herpes zoster.
Herpes, yeah.
Which one?
Genital
Option?
herpes.
Genital herpes.
Same.
Genital herpes.
Yes, very good. Genital herpes. Okay, let's go to the question first. These options are a bit tricky. Okay, 38-year-old woman presents to the accident and emergency with generalized tonic-clonic convulsions. She becomes unconscious. An ultrasound report is found in her medical record, which shows a live 10-week intrauterine pregnancy. Buzzword here is she is pregnant and she has been collapsed.
Benzodiazepine.
Read the option first. I said earlier that this is a bit tricky question, tricky options.
D. Option D.
Airway face massage.
She collapsed already. So yeah, so
Yeah, maternal collapse. Just remember that guideline. We do have a green top guideline on that, maternal collapse. She's 10 weeks pregnant and she has been collapsed. So what
Then
will you do at first instance?
B.
B, ma'am. B,
Airway
ma'am.
face. B.
Very good. Option B, A, B, C. Just remember airway, breathing, and circulation. So you will check her airway, you will give her oxygen mask, you will cite an IV access. Clear?
Yeah.
Yes, ma'am.
If you read the maternal collapse guideline, it starts from resuscitation, that is ABC. Okay. Number 18, a 23-year-old primary gravida is noted to have a blood pressure of 150/90 at a routine antenatal visit. She recollects mild intermittent headaches, but is otherwise asymptomatic. She is now 18 weeks pregnant and has no proteinuria. She is 18-week pregnant, no proteinuria, with high blood pressure. Okay, options.
G.
G.
Sural
Okay.
G,
labital.
ma.
Other. E.
No, commence labetalol.
Okay, let's go to the question again. It's 23-year-old primey having blood pressure, high blood pressure at a routine visit. She is 18 weeks pregnant and no proteinuria for now. Answer is G. Commence oral labetalol. She is a case of chronic hypertension. Okay, she is a case of chronic hypertension, so you need to start her antihypertensive. And the first line antihypertensive according to our NICE guideline is start labetalol if she is not having with any contraindication. Okay. Number 19, a 30-year-old second gravida records a blood pressure of 160/110 when she attends the day assessment unit for her fetal monitoring. She is now 30 weeks into her pregnancy with monochorionic monoamniotic twin gestation with no major complications. Her urine analysis shows 4+ proteinuria. Further analysis shows serum uric acid of 6.8 and a normal complete blood count with mild elevation of liver enzymes. An intravenous access is obtained immediately. Blood investigations are sent. The bladder is catheterized and she is shifted to the high dependency unit. She is
Magnesium.
having high blood pressure along with proteinuria.
And
Magnesium.
HELP
L.
syndrome.
IV, L is
L.
HELP syndrome is also there.
Yes. HELP syndrome. Yes. So these all are actually pre-monitory sign of eclampsia or impending eclampsia. She is having impending sign. So we need to start her on intravenous Maxel, 4-gram bolus dose followed by 1 gram per hour infusion, maintenance dose. Yes, option L is the answer. Number 20, a 30-year-old primary gravida is admitted in spontaneous labor at 37 weeks gestation. Her antenatal period was uneventful. Her blood pressure reading is 140/90 with 1+ proteinuria. She is now having regular uterine contractions and vaginal examination revealed a 3 centimeter dilated cervix. So she is already on labor and she is having high blood pressure with 1+ proteinuria. What will you do first? Just think about your patient that you are attending a laboring patient. What will you do at first instance?
D.
Betamethasone
No,
in
she's in
laboring
labor.
patient.
She's in labor.
She has already 3 centimeter dilated cervix. Hydralazine, IV hydralazine. Okay.
I think D.
Any other?
D.
blood investigation. D, ma.
Yes. Answer is D. Think about your patient that you are dealing a patient, she is on labor table and she is having 1+ proteinuria along with high blood pressure. You will send the blood investigation first. If she is having eclampsia, you need to see the uric acid also, because you need to, by seeing the uric acid, we usually take decision, we need to deliver early or not, because uric acid always indicate the fetal compromise. Okay. And so the blood investigation, you need to send the blood investigation first. If she has already developed HELP syndrome or not. Okay, so send the blood investigation first.
Okay.
Clear?
Yeah.
Okay. Now these are options. Okay. Number 21, a 5-year-old girl presents with burning on micturition and vulval scratching. On examination, the vulva is noted to have a well-demarcated white area around the introitus. The overlying skin appears thin with extensive fissuring. The perianal area is involved. So the buzzword here is the girl is only 5 years old, vulval scratching, white, well-demarcated white area around the introitus.
Lichen sclerosis.
Lichen sclerosis. Yeah.
Yes, it's lichen sclerosis because we need to remember that it's written in the guideline that lichen sclerosis can occur at any age. It can be in 5-year-old girl also. It could be there also in a postmenopausal woman. And the common features are extensive pruritus. If you examine the vulva, you can see the excoriation scratching mark, figure of 8 distribution of the lesion, and the lesion is white. The area becomes thin. Okay, these all are features of lichen sclerosis. Number 22, a 23-year-old woman presents with vulval itching. On examination, there is a well-demarcated symmetrical lesion involving the labia majora and minora and extending to the genitocrural folds. The lesions appear beefy red with scaling. A biopsy shows papillomatosis, parakeratosis, and neutrophil exocytosis.
Psoriasis.
Psoriasis.
Yes, good. Psoriasis, just remember that symmetrical lesion. Symmetrical is the buzzword for psoriasis. The another one is beefy red or salmon pink. Okay, salmon pink or beefy red, symmetrical. These two are buzzwords for psoriasis and also involve the vestibule. Okay, we can't see the scaling. Only if it is involved the labia majora, then only we can see the scaling. Just remember these lines. Psoriasis can be there with scaling and also without scaling. And this is the most common feature, histological findings of psoriasis: papillomatosis, parakeratosis, and neutrophil exocytosis. Okay, remember these 3 words. If we do the slide examination, if we do the biopsy and do the histological examination, we can see these. These are buzzwords for psoriasis. 23, a 34-year-old woman presents with a burning sensation in the vulval region. On examination, the vulva is erythematous with marked edema and numerous small superficial ulcerations. The inguinal lymph nodes are enlarged and tender.
Herpes simplex. Yeah.
Yes, it's a straightforward common, it's herpes simplex. Now, let's do some oncology. Okay. A 60-year-old woman has a laparoscopic bilateral oophorectomy for a persistent ovarian cyst. Her serum CA-125 is 50. The ovarian capsule is noted to be intact, but during the operation, the cyst ruptures. Peritoneal washings prior to the rupture are clear. The contralateral ovary is normal. Histology confirms an ovarian carcinoma. So the buzzword is the capsule rupture due to operation or surgical spillage is there.
1C1.
So which stage?
1C1.
Yes, very good. Just memorize the FIGO staging of all cancers. You will get 1 or even 2 EMQs from these FIGO guidelines, FIGO staging of different type of cancers. A woman is diagnosed with cervical cancer. The carcinoma has extended into the pelvic side wall. On rectal examination, there is no cancer-free space between the tumor and the pelvic side wall. The tumor involves the lower third of the vagina. There is unilateral hydronephrosis. Which stage?
3B. 3B.
3B, yeah.
3B.
Yes, 3B. 3B. This is straightforward question. See, you can score the good mark from the oncology module, because this is definitely you will get 1 or 2 EMQs from this staging, tumor staging. Okay, a 90-year-old woman is diagnosed with vulval cancer. Imaging suggests metastasis to both inguinofemoral and pelvic lymph nodes.
Last stage.
Which
Stage 4.
stage
Stage
of
4.
vulval?
Four.
Stage 4, yeah, 4 be last stage.
Last
What is
stage.
last stage? Yeah,
That is the 4, stage
4B.
4.
Yeah,
4.
yeah, right, 4B. Okay. So these are options regarding urogynecology. Do you know one thing? Most of you are will be giving exam in September, but you can score good marks from gynecology. Gynecology is a bit easier. Nothing is easier. First of all, nothing is easier. But if you want to make a that which one is harder, which one is easier, so gynae is a bit easier than obstetrics. So do the gynecology very well. Okay. Okay. Number 27, an 83-year-old woman in poor medical health with urodynamic stress incontinence and normal voiding parameters. Remember her age, 83-year-old woman, and she is having stress incontinence.
Intramural bulking ಏನು H ನ?
Why you want to give intramural bulking agent? You are right. Your answer is right, but tell me why
She's poor
actually
medical
bulking
health.
agent?
She's
So
not fit for
she's
surgery.
unfit for the surgery, that's why.
Surgery.
Yes, that is the point. She might not fit for surgery. Her age is very old, frail. 8-year-old with a poor medical. Yes, the answer is intramural bulking agent, H. Okay. A 44-year-old woman with urge incontinence and severe detrusor overactivity on urodynamic assessment. This is unresponsive to conservative therapy and anticholinergic medication. So the woman is have urge incontinence. She has tried conservative therapy or lifestyle modification and also tried anticholinergic medication. The next is what? Which?
Botulinum toxin.
Yes, botulinum
Yeah.
toxin. Right, botulinum toxin. Number 29, a 56-year-old woman with urodynamic stress incontinence and no previous surgery. Her family is complete and there is no prolapse on examination. According to NICE guideline, which one is the first option?
Colpo suspension.
Colpo suspension.
Very good.
G.
Colpo suspension. Yes, no previous surgery. That is, she will go for primary surgery. If the primary, just remember one thing, if the primary surgery fails in stress urinary incontinence, so before going to the second surgery, you will do the urodynamic test. It's written.
Yeah.
Yeah. So these are all from my side. Thank you. Thank you, everyone. Me and Dr. Zaib, actually, we will be doing yeah.
Thank you so much, Dr.
Actually,
Maliha.
we will
I
be
think these guys are superb. I have been silently
yeah,
observing
yeah,
and
yeah, yeah.
trying to answer as well. So well done, guys. You all are, I mean, superb. You all are going in right direction. Okay. All you need is little bit more practice. Okay. What I can gather. Okay. I don't want to, the point out specifically, but because this is the high time that I mean you have to practice as many questions as possible. So I mean this is going to be the sincere and honest advice from our side that do practice as many questions as possible along with your revision. Okay.
Perspective period shown nothing with the Ross closed
Very good.
creating big size uterus. No formation tender.
I have question, please.
Yes. Is there any question?
I have one question.
Yes. Yes. Please, Deepak.
No, I need one suggestion. I have
Yes.
next January, and I attend the 5 days question workshop in first.
No. I don't think so. You need it at the moment. Okay. So it's better to take it once you are ready, because if you will not solve questions properly, so of course you will feel upset. Okay, you will be upset that okay, see, so your start should not be lousy at all. Okay, your start should always be very good, and it should always be very confident. Okay, and it shouldn't be lousy at all. Okay.
Okay. Thank you.
Okay. Good.
Dr. Zaib, please, about consent advices, can you guide something? Because I have not done it and I don't know how to do it.
Consent advices. I think there are multiple summaries on your MedExam expert website. Okay, so you can go through them.
I have a suggestion for this consent advice guideline, Dr. Sumaila. Hello.
Yeah, please, Dr. Maliha,
Yeah.
please.
So you for the consent advice, you can do one thing. You can make a small note for each. Like we do have around 9 to 11 consent advice guideline. So you make a small note and hang it in front of your table and revise it daily, because you will definitely going to get question from consent advice guideline.
1 or 2, 3, because these are numbers. Okay, that for example, the chances of having hysterectomy in the placenta previa. Okay, chances of having the severe complications in the laparoscopy, and how many the ureteric injuries are going to be missed in the the laparoscopy. So these type of the important questions, so they are going to come in exam. So altogether what you can do is that make your own notes, that like Maliha said now. So you can do that. Okay, so it has got the different things. Okay, it has got the common risk, rare risk, and the uncommon, and I think serious risk. Okay, so you can make a chart of yourself, and you can make columns, and then you can just like try to revise it. Moreover, there are plenty of almost all the consent advice summaries are available for you on the MedExam expert website. Okay, you can quickly go through them and extract your the whatever information is needed. So don't worry about it. 2 to 3 questions can come from there. So don't put extra emphasis on that. Rather, your focus should be 60%. Okay, green top guideline, nice guideline, and dog articles. Okay.
Thank you so much.
Okay. Very good. Any other question, guys?
Hello, Dr. Zaib.
Yes.
Can I ask a question? Is it mandatory to do last 3 to 5 years talk articles?
Well, sweetheart, it's better. It's a good idea that if you can do, like I said earlier, that if you can extract the important, the talk articles, like in recently July exam, we had, the almost, Maliha, remember we were discussing other day, the all 5 topics are very much important. Okay. The one is, urogynecological problems, how to deal with pregnancy. One is hyponatremia in pregnancy. Okay. The other is, I think, like these type of, the topics. So of course, if these kind of topics are there, and yes, on the other hand, if the topics are very advanced, for example, if they are the focusing on advanced laparoscopic the kind of thing, so of course that is not going to be our domain at the moment, because we need the basic stuff at the moment. Okay, so you can simply just go through the all topics, and then you can scan yourself that okay, this looks important to me. And moreover, you don't have to overlook maternal medicine topics. Okay, because almost if the multiple almost 50% of the topics are being covered by green top guideline and the nice guideline, rest of the 50% are covered by the dog articles. Okay, doesn't necessarily mean that these are in the recent 3 to 5, but rather, you know, they are a little bit old as well, like asthma, like thyroid. Okay, I think asthma is in 2013 or 14, if I'm not mistaken. Okay, likewise, you know, the thyroid as well. Okay, so this is how you extract. Okay, this is how you extract.
Thank you so much.
Okay, sweetheart. Okay, okay. Okay, any other question, guys?
Thank you so much, ma'am. Please, because I am driving while I am listening to the lecture, lichen sclerosis in young age also, right?
Both. Lichen sclerosis has 2 peaks. Okay, young age and old age. It has 2 peaks of ages. Yeah, it can come.
Yes, yeah, same feature. I mean, same.
Yes,
same
yes, yes,
picture.
same features, of course. Same.
Thank you so
Same
much.
feature, same treatment, and same follow-up.
Exactly. It
Thank
has
you so
2 peaks of ages. Okay, very good. Thank you so much, guys. You know, it was really wonderful, you know, having discussion with all of you. So all the very best from all of you, you know, the all of us to all of you guys. Okay. And if anybody is interested in the workshop, so please do contact us and do join us. We will be happy to coach you. We will be happy to guide you through. Okay. So please, you know,
Yes, yes.
make us,
This is the way actually we will be solving. We will be solving questions in the workshop also. We will be solving the recalls, and we will be giving more emphasis on EMQs, how to solve, how to pick the buzzwords actually.
Exactly. Very well done. Okay, thank you so much, guys. So if there is no question, so we would like to take leave, and we will leave you on your own. Okay, study well, stay focused, stay motivated, study hard. There is no shortcut to success. Always remember. Okay, there is no shortcut to success at all. All you need is, you know, the full determination, hard work, and of course, you know, the focused and smart study. All right. Thank you so much. Good
Thank you
night.
so much.
Bye bye.
Bye-bye.
Thank you, everyone.
I love this.
Thank you, Dr. Maliha. Thank you.